Also remember that inspiration is active, but exhalation is passive. When? When is expiration passive? At rest. Remember, with exercise becomes active, and those very small muscles in the ribs are responsible for it, and that's why you get those side splints. At rest, the lungs tend to get smaller, is balanced by the tendency of the chest wall to expand. Our lungs want to collapse on themselves. Your chest wall keeps wanting to flail open. But because they are attached and they're connected by that pleural lining, the lungs will never collapse. The chest wall will never flail open because they're both kind of pulling on each other. So when we breathe in real deep, the chest wall expands. Our lungs get obviously very, very big. As you breathe all the air out, your lungs are getting smaller and smaller, but your chest wall is being collapsed in at itself as well. You get what's called pneumothoraxes, when air sometimes, or blood or fluid, can get in between the lining of the pleura and the inner lining of your chest wall. They separate, and those lungs will just collapse because nothing's keeping it attached to the wall anymore. We have connective tissue. We have the surfactant, which helps with O2 tension, helps keep the alveoli expanded and open. The more open they are and expanded, the more surface area we have for gas exchange. We have conducting airways, and we have respiratory units or airways at the end. Remember, in the beginning of the airway, it's all conducting. We're just moving the air from the mouth, trachea, bronchus, main bronchus stems, and eventually you get to the smaller units where we have gas exchange occurring. In the proximal conducting airways, we have ciliated, pseudostratified columnar epithelium. Just remember it's ciliated, so this is where those little hairs are that are going to beat up the mucus, so you can cough out any allergens that got trapped in the mucus that you breathed in. So those cilia are there to help keep the mucus moving. These cilia is what gets replaced with like chronic bronchitis, smoking for so long. We lose the ciliated cells. And therefore, you can't expel those mucus, which has the trapped bugs in it. It stays in your lungs longer, and that's why you get sick. As we go further down, smooth muscle and secretory glands are reduced. Okay, we don't want these secretions in the alveoli. Why don't you want those type of secretions of mucus in the alveoli? What's it going to do? The surface tension is going to be affected, but also the distance that oxygen has to travel is going to increase now because you have mucus there that shouldn't be there. That's increasing the distance from the air to the capillary. Anything that increases that distance is going to slow down diffusion because the distance oxygen and CO2 have to travel now is being widened because of the mucus that shouldn't be there. Obviously, our lungs are divided into lobes, and those terminal respiratory units is that final unit of the lung, and that's where gas exchange occurs. And then here's just another drawing. This is right from physio, same picture I used then. But again, here's the separation from the conducting airways to the terminal respiratory units. Obviously, the surface area starts to increase because we're starting to get all little grape-like alveoli. That increases surface area for diffusion. And again, just anatomy, just review of, we have our alveoli and the duct and whatnot. Here's a picture looking at our blood supply. We can see here a lot of smooth muscle. All these bands of pink are smooth muscle. So when we have like an asthma attack, these smooth muscles expand and they get big, they get edematous. And they squeeze on that bronchus, reducing the lumen, so you start wheezing because of the smooth muscle contraction, reducing the lumen size. We do have lymphatics here as well. So obviously, lymphatics, what's the purpose of lymphatics? Drainage. Excess fluids we don't need in certain areas. That's what the lymph is for, to get rid of it. I'm not going to go much detail about all this, but it's all there. Our nervous system. We have efferents and we have afferents. The main afferent for the lungs is the vagus nerve. The efferents, these parasympathetic fibers, muscarinic. Remember, muscarinic is the type of receptor that's going to go to. Cholinergic tells you it's acetylcholine. So we know it's parasympathetic. And these mediate bronchoconstriction, pulmonary vasodilation, and mucus gland secretion. So that's what the parasympathetic fibers will do to the lungs. Sympathetic fibers, bronchial smooth muscle relaxation. So remember, fight or flight. Sympathetic. We want our airways nice and big for we can get a lot of air moving, so we can get a lot of oxygen to feed all of our muscles. So we want smooth muscle relaxation. We want that airway to get as big as possible. And then we also have this non-adrenergic, non-cholinergic system. So this is not parasympathetic, it's not sympathetic. It's their own thing, and this is your ATP, nitric oxide, which we talked about a little bit in the neurohormonal changes of the cardiovascular system. ATP, nitric oxide, and these are obviously inhibitory events, including bronchodilation. The afferents, pulmonary stretch receptors. Okay, your lungs have stretch receptors. What instance would your lungs start becoming stretched more than usual? During what activity? Exercise. So if our lungs are expanding more, that impulse is going to the brain to be like, hey, our lungs are expanding, we might be exercising, let's increase our heart rate. Because if our lungs are moving more, we're getting more oxygen into our blood. How do we get it moving faster throughout our body? The cardiovascular system has to kick in, obviously, make it go faster. So we're breathing more, we're starting to exercise, okay, heart rate needs to come up to increase the supply of the oxygen to our muscles. We have irritant receptors. These are mainly in your proximal airways. Remember, the proximal airways has all that cilia. So cough, mucus secretions, that's your irritant receptors to help cough whatever you need it out. Last thing are these C fibers or these juxtacapillary J receptors. These respond to mechanical and chemical stimuli. If you ever had very, very hot wings, that's your J receptors kicking in. But because of the irritant of the capsaicin that you're eating, you're also inhaling it as well. Irritates the lungs, causing you to have that type of breathing pattern. Mucus secretion, cough, all those things start going up. So those are your juxtacapillary receptors that do all that. So this is kind of how it looks when everything's put together. We have our pulmonary artery, the bronchus there. We have the lymphatic system that's draining off of that pulmonary artery. We have the pulmonary veins, which again come very close to the alveoli because they're going to have to for gas exchange. Ventilation, obviously air going in and out. That's all we're talking about is just air. So ventilation is just air movement. It's nothing to do with oxygen. Obviously, it's going to be implied it's going to have an effect on the oxygen, but when we talk about ventilation, it's just air movement. Obviously, the chest wall favors being expanded, and that helps aid in the compliance of the lungs. What is compliance? It's the same values that we do in the heart. Holding a big volume with minimal changes in pressure. Same principle in the cardiac and the lungs. The lungs have a natural tendency to recoil. Lungs want to shrink. They want to get all the air out and just get as small as possible. And obviously that's determined by the shape and structure of the thoracic cage. What do you guys do in PD to assess thoracic cage? That's looking at, are you breathing in and out? AP diameter, right? You just look at front and the side to see barrel-chested or not. That's looking at the thoracic cage. When we start talking about chronic bronchitis, they become blue bloaters. They're going to have a barrel cage, like the thoracic cage expands because over the excessive lung volumes, the ribs expand. Pulmonary function tests. Okay, they include spirometry. We're going to measure the airflow rates, how fast or what volume of air is being moved in and out. And it also calculates your lung volumes and your capacities. Can be done at rest or while exercising. This semester, you have, for PD, we're going to have 2 sim days. One's a pulmonary, one's an EKG cardiac one, where you guys will, you'll rotate through kind of like grand rounds like you did on Tuesday. But one of the sections will be you guys doing EKGs on each other, putting the leads on, and you actually look at the strip and see what it says. The other thing we'll do is pulmonary function tests where you guys can volunteer and actually perform the test and see how your lung ages are. Everyone likes to see that because it tells you your like predicted age of your lungs. And some people get like 50 or 60 years old when they're like in their 20s, they all start freaking out. The thing with pulmonary function tests, has anyone done these before? You have asthma. So the important thing with these tests, it's all user dependent. It's not like an x-ray where you just stand there, okay, I'm gonna snap a picture. The person doing the test has to perform this, and they're not easy to do. So it does take a couple of times before you do this. And if you don't know what you're doing or you get embarrassed by your classmates, you don't want to give the full effort, the values won't be right, and that's why it says your age is old, because you're not giving a good effort. So we'll talk about pulmonary function test. This is what a pulmonary function test is. What is this thing on the right? It's an incentive spirometer. Okay, we do this a lot with post-surgical patients to keep those lungs expanded. So we have them inhale and do certain things to keep that bubble up, breathe in, breathe out to keep that bubble up in a certain area to help expand the lungs. So just to review, tidal volume. Right now, all of you are breathing at a tidal volume. Breathing in and breathing out. Breathing in, breathing out. Whatever air is moving is your tidal volume. Tidal volume is also similar to your stroke volume. It's the amount of air leaving the lungs, and stroke volume is the amount of blood leaving the heart. They mean the same thing. Inspiratory reserve volume is the amount of air that you can breathe in above your normal breath. So you breathe in, everything's fine. Okay, say, take a big breath in all the way in. Breathe in all the way in. All that extra air that I can get into my lungs above my tidal volume is my inspiratory reserve volume. How much reserve can I have in my lungs? Can I breathe in? Expiratory reserve volume. Right now, you all have air in your lungs. Don't breathe in deep, but just breathe out. And keep breathing all the air out. There's a lot of air in those lungs that's just floating and diffusing oxygen and whatnot and mixing with the air. But there's still a lot of air in our lungs that is not really moving with every tidal volume or every tidal breath. So all that extra air that's in our lungs beyond that tidal volume is our expiratory reserve volume. The residual volume is the amount of air left in the lungs after you've breathed all the air out of your lungs. There's still a little bit of air left. What would happen if you got rid of all the air in your lungs? They would collapse, so you can't. That's the same reason why stroke volume is never 100%. There has to be fluid in the heart or it's not going to work. So there has, if you like prime an engine before you start it, to get the fluid moving so that the pump will work. Same thing with the heart. And this thing shut down. Okay. And then your capacities, remember capacities are always an addition of lung volume. So your vital capacity is IRV plus TV plus ERV. All the air you can get into the lungs and all the air you can get out of your lungs. That's your vital capacity, the life, air you can get for life. Your total lung capacity just adds in the residual volume. So what is the total amount of air your lungs can hold? That is your total lung capacity, but the amount of air that you actually can exchange is vital capacity. And again, here's just a way of graphically looking at it, and on the side on the left, they have all the different values and the numbers. So remember, tidal volume, breathing in, breathing out. Okay, all the air above a breath is your inspiratory reserve volume. All the air you can get out below is your expiratory reserve. Okay, all together is your vital capacity, and there's your residual volume. And you guys will do this in lab later this year. Now, there are other things we want to know about besides just your lung volumes. We want to know how fast you can move air in and out of your lungs. So we do what's called a forced vital capacity. And what you have to do is you're going to breathe as much air in as you can and as fast as you can, and then breathe all that air out as fast and as forceful as you can. The reason is we want to know FEV1. We want to know how much air can you get out of your lungs in the first second of you breathing out, how much air came out. Okay, so what you have to do is you hold it to a mouthpiece. You have to plug your nose so that all the air comes down to your mouth. And we're going to say go, and you go, it's fast. Everyone's going to be embarrassed when you're doing it for your friends. It doesn't matter, just do it. But you want to know how much air, so I breathe in, I have a certain amount of volume in my lungs, let's say it's 4 liters of air. How much of those 4 liters can I get out in 1 second? That's what we're trying to figure out. Because if you have an obstructive lung disease, what do you think is going to happen to your FEV1? It's going to go down because there's obstruction to flow. That's what COPD is. Chronic obstructive pulmonary disease. There's an obstruction to flow, so what you can get out in 1 second is going to be affected by that. So that's what we want to know. So then what we do a ratio, FEV1 to FVC. Out of all the air that I had in my lungs, how much of that air came out, and we assign a percentage to that, just like stroke volume. And a normal is 80%. Okay, so in a normal, healthy lung, you should be able to get out 80% of the air in the first second of exhalation. Okay, obviously diminished in people with obstructive, but it's increased in patients with restrictive lung diseases. And we'll get to more detail about why in a little bit. So this is what it looks like when you do this pulmonary function test. We have our x-axis, which is the volume of air moving, and we have flow on the y-axis. Above the line is expiratory flow, breathing out. Below the line is your inspiratory flow. So as you breathe in, we'll do the normal, which is the blue. And that's how those work. So when you're breathing in, it goes that direction. When you're breathing out, it goes in that direction. So you have your normal, and let me just erase mine. Okay. So your normal. Now, let's look at the obstructive pattern. Okay, obstructive, I'll put it in green. Because they have an obstruction, the obstruction is really affected more on exhalation than inhalation. If you look at the inhalation, it's still pretty close to a normal one. But the problem comes in when we get to exhalation. It's blunted because there's an obstruction to flow. We can't get all the air out. So obstructive, the volumes are okay. The flow is not. for obstructive diseases. The flow is affected. The volume that you can get in and out of your lung is not. You just can't move it very well. Restrictive diseases, and let me change the color. Restrictive has a different look to it. Very narrow. So because it's narrow, what's reduced in restrictive? Volumes. So remember, restrictive, it's like trying to breathe with a straitjacket on. Okay, wrap your arms around your chest and try and breathe in deep and everything. You can't do as well as you could when your lungs are not restricted. So restrictive, they have a problem. Volumes are reduced. They can't fill. Just like restrictive cardiomyopathies. They can't fill. They can still squeeze just fine. The blood can still move. It just doesn't fill very well. Restrictive lung diseases, the same thing. They don't fill very well, but they have heightened recoil. And that's why their flow is accentuated. So the flow will put increase, but it's due to recoil. Does that make sense? The recoil is greater with emphysema, not really emphysema, it's obstructive, but we'll go through the restrictive diseases. They're more of the infiltrative ones. Sarcoid, the same things that are infiltrative diseases for the heart can also affect the lungs as well. The lung tissue doesn't move very well, doesn't expand very well, and then they have problems with volume issues. They can't fill very well. That's why that width is very narrow compared to the other ones. Immune structure and function. Normal day, we breathe in and out about 7,500 liters of air. Remember, it's just air, not oxygen, each day. All blood goes through the pulmonary system. So anything you breathe in will get exposed to blood because all of our blood goes through the pulmonary system. So any of those toxic, infectious, inflammatory insults can get into your system. We have two types of defense. We have non-specific, which is just clearance, secretions, cough, trying to get that stuff out. And we have our chemical ones, your antibody-mediated, antigen-presenting cells, all those things we've already talked about with regards to our immune responses. Remember, gas exchange occurs in the alveoli. We have very thin capillaries that surround all the alveoli, and it allows for a really, really effective gas exchange to occur. So when it comes to the oxygen content of the blood, how much oxygen is even in the blood is going to be affected by the arterial PO2, what's the pressure of oxygen in the blood, and our hemoglobin level. What kind of things are going to affect arterial PO2? Altitude, okay? Go to Denver. Your PaO2 drops because there's less pressure. Oxygen content goes down. Your hemoglobin may be the same, but the arterial PO2 dropped. So the oxygen capacity in the blood or the content goes down because of the altitude that you're in. So that's just talking about, is our blood oxygenated, yes or no? And it's related on the arterial PO2 and the hemoglobin level. The next thing we want to be concerned about is tissue delivery of this oxygen. So yes, we have it, but can it get to where it's got to go? And that's where the cardiovascular system kicks in. Cardiac output. Because we have to deliver these trucks everywhere. And the cardiovascular system provides the energy to move this oxygen wherever it's got to go. And obviously, whatever the oxygen content of the blood, which is what all this is referring to, and then cardiac output just moves it around. And this kind of just breaks down our oxygen delivery to our tissues is related to blood O2 saturation, which we know is affected by hemoglobin level, and our blood O2, which is affected by airway, breathing, and the FiO2, which is how much oxygen we're breathing in. Our stroke volume, we know from ad nauseum from all the cardio stuff, preload, afterload, and contractility are the main ones that affect cardiac output. This is a good summary slide, kind of putting the lungs and the hearts together as far as can we get this oxygen even delivered to our tissues. CO2 is carried by that carbonic acid, CO2 dissolved in plasma, and that little bit left over is that carbaminohemoglobin. CO2 is 20 times more soluble in plasma than oxygen, and that helps with offloading oxygen at the tissues and offloading CO2 at the lungs. So let's talk about breathing. Well, let's take a break. Come back at 10:30, and we'll start talking about breathing. Okay, let's keep moving here. So let's talk about just the act of breathing itself. Lungs don't require a lot of oxygen consumption just for the metabolic processes of the lungs itself. However, when you start getting into people with lung diseases, energy requirements start to go up. And obviously even more with exercise. The two components that affect our breathing are the elastic forces and any type of resistance to airflow. Remember, we have our zones of perfusion, so while we're all upright right now, gravity is keeping the blood mainly in zone 3 at the base, and that's where a lot of the perfusion and ventilation is occurring. In the apices, up at the top, we have less cardiac output, but increased ventilation. That's why during rest, the apices are also known as ventilatory dead space. They're ventilated but not perfused in the apices. So we have to match our ventilation to our perfusion. And we look at this number a lot. So in order for the lungs to bring ambient oxygen close to our blood, obviously we are at the same place at the same time. So you have to have ventilation in the area and you have to have perfusion. They must be matched. Okay. The ratio of ventilation to perfusion is highest at the apex and lowest at the bases. Why is that? So it's VQ V over Q. And we're saying that in the apices, the VQ ratio is the highest. So if we have ventilation of 10, we only have 2 for cardiac output. Our VQ is 5. Now let's go to the bases. And in the base, let's say our V is still 10, but now because we're at the base, we have more volume there. We go to 5. And you see how the VQ is starting to come down. The more perfusion you have, the VQ goes lower. The less perfusion, the VQ goes higher. Does that make sense? Okay. So when you have a mismatch, a VQ mismatch is the reason for most oxygen and carbon dioxide exchange abnormalities. And we'll talk about the different, where does the VQ scan come into play? We'll talk about in different types of diseases, what the VQ scan is going to show. So again, normal ventilation is 4 liters of air per minute. Our normal cardiac output is 5, right? That doesn't change, it's still 5. So a normal VQ ratio is 0.8. That's your normal VQ ratio, so just remember 0.8. If the VQ is greater than 0.8, that means we have too much ventilation, not enough perfusion. So as this number goes up, perfusion goes down. So give me an example. When would perfusion go down in the lungs? Perfusion. Pulmonary embolism. We have a clot in the vasculature of the pulmonary system. You're not going to perfuse that area. It's only going to get ventilated. And you'll see the VQ number go up because there's no blood in that area. When VQ is less than 0.8, it means that perfusion exceeds ventilation, therefore poor ventilation. We're not breathing enough, or you have a blocked airway, which can happen with like mucus plugs, with all that bad mucus that builds up in people who can't cough it up because they lost those ciliated cells. Ventilation goes down. But the perfusion is still good. The vessels are still good. So when VQ goes down, ventilation is the problem. Okay, so you can see here, our normal VQ, 0.8, we have normal alveoli are perfused, and they are also ventilated. When we go to low VQ, your alveoli shrivels up because we're not breathing. It's a ventilation problem. Your endotracheal tube in the mainstem bronchus. So if you're ever intubating anyone, you have to check ventilation for both sides to make sure you're adequately ventilating the lungs when you've intubated them. If you only hear breath sounds on one lung, that means that your endotracheal tube went down a bronchus. It didn't stay in the main bronchus. It went down one of the left or the rights. And you're only ventilating one lung because of where the tube is. So that's when VQ would go down. We're not ventilating. High VQs. Alveoli is ventilated but not perfused. Cardiac arrest is one. Your pulmonary embolism is one as well. So again, dead space ventilation. They're being ventilated, but they're not being perfused. Why is blood not getting there? Our control of breathing, managed by our diaphragm, intercostal muscles, and abdominal muscles. Remember that CO2 is the main driving force for our breathing, not oxygen. We have plenty of oxygen in our blood that's circulating around. It's the buildup of CO2 that causes your breathing rate to change. We have inspiratory or expiratory neurons. They integrate our breathing. Therefore, we have spontaneous breathing without conscious thought. So we can breathe while we're sleeping. We don't have to worry about maintaining brain activity to watch our breathing. And that's the connection between like sleep apnea and like having a bunch of other problems, because being tired throughout the day is because when you have sleep apnea, your brain doesn't really shut off at night because it's got to monitor your O2 and CO2 levels because of your sleep apnea. That's why they don't sleep very well and they wake up tired, because their brain never actually shuts off to allow full rest to occur. We have our sensory input, and obviously we're looking at O2 and CO2 concentrations in the blood. We have carotid bodies that send those signals to the brain so we know what our pH of the blood is. We know that based off the CO2 and the hydrogens that are floating around. We'll know our CO2 levels and so forth. So let's move on to some diseases now. Let's talk about obstructive lung diseases. We have asthma and COPD. COPD will be broken up into chronic bronchitis and emphysema. These are all obstructive lung diseases. We separate them out because what's the main difference between asthma and like chronic bronchitis and emphysema? Asthma is reversible. You can not have asthma attacks anymore if you just avoid the allergens. Once you get bronchitis and emphysema, they're not going away. They're chronic. They're not reversible. So when it comes to the lungs especially, and when you get into pulmonary with Professor Singh and you do cardio with Dr. Ovalle, you're going to see a lot of these standards pop up. And they're very common with the heart and the lungs. They're all over the place. But one of them we're going to learn about now is the gold standard. And this has to do with COPD. So there's this whole thing here about being preventable and treatable with COPD. Obviously, what's the biggest way to prevent COPD? Stop smoking, right? That's why it's preventable, because if you don't smoke, you shouldn't get chronic bronchitis. There is a way you can have a genetic abnormality that can lead to emphysema, which we'll get to. But for the most part, emphysema is also caused by smoking, so on and so forth. So with these GOLD criterias, they base it off of your spirometry results. So if you're GOLD 1 with mild COPD, remember we're just classifying. You're going to learn about classification, and with heart failure, there's heart failure classifications, 1, 2, 3, and 4. GOLD criteria classifications for COPD. You want to risk stratify your patients. That will tell you, do I need to worry about prevention of heart disease? Do I need to put this patient on a low-dose aspirin if they have underlying heart disease and other risk factors? Are they at higher risk for certain diseases, complications we have to be worried about? So I'm not going to go through this very detailed, but I want you to bring up, again, this FEV1, 80%. Okay, 80% was that magic number. Above 80, we're okay. That's normal FEV1 or over FEC. As you start going into more severe forms of COPD, you can see how bad. You get to the GOLD criteria 4, FEV1 is less than 30%. So 30% of the air that's in your lungs you can get out in that first second. That shows how severe the obstruction is. Yes?
Why does it say predicted?
So the predicted is what we predict you will perform based off of your age and your height and your sex. So FEV1, when we actually get it, it'll be less than 0.7 or less than 70%. So the predicted, this is where I say that you're going to have like ages of your lungs to be like 50 to 60 because they're predicting it off of your age, sex, and height. Why are those important? Why is your sex important for talking about lungs and predicted value of your lungs? The bigger you are, the taller you are, the bigger your lungs are going to be, the bigger the lung volumes. Same thing with male versus female, bigger bodies. The taller you are, the bigger your lungs are going to be. But that's why we do it by a ratio, because the ratio equalizes all that. It doesn't matter if you can breathe in and out 5 liters of air or 4 liters of air. What percent of that can you get rid of? So the FEV1, that percentage kind of normalizes it. The predicted values are based off of those things. So this is that little Venn diagram about COPD. Again, you have asthma on one side, you have your emphysema and chronic bronchitis is on the other. There's still airflow obstruction, just that depending on when it happens, what are the underlying causes. Here's another one for you. Okay, so obstructive lung diseases. Resistance to airflow due to reduced airway caliber or the lumen, reduced in size, however you want to call it. That lumen, the bronchus, the trachea, reduced in size, less airway can get through. Results from anything within the lumen. Okay, obstructing secretions are also obstructions. Any processes in the airway wall. Okay, airway wall thickening. Okay, can be seen with inflammation from the asthma, chronic bronchitis, or processes in the structures that support the airway. And emphysema, what emphysema does, it destroys the elastic properties. The elastic tissues are destroyed in emphysema. So that nice recoil, the thing that's keeping those alveoli open, is gone. And all those alveoli burst and they turn into one big alveoli, not little ones that have more surface area. And we'll go through all these little things that happen as we go through the PowerPoint. So, obstruction can be reversible, and that's asthma. It's reversible. You have your airway obstruction, you have your event, you recover from it, and you're fine the rest of the time until another asthma attack happens. There's no problems with your FEV1 when you're not having an asthma attack. Everything's fine. Irreversible causes is your chronic bronchitis and emphysema. They're irreversible. Once they start, they're not stopping. They're not going to get better in between. Yes, you can go on medications that will help your breathing, help with mucus and all that stuff, but it's not going to go away. Okay, so moving on to asthma first. Genetics and environment play a role with asthma. So there is a genetic component, but obviously your environment. It's a disease. Asthma is a disease of airway inflammation and airway obstruction, or airflow obstruction. It's intermittent. It comes and goes. They get wheezing, chest tightness, shortness of breath, cough, and bronchial hyperresponsiveness. Where else have we learned about hyperresponsiveness? Allergies, right? Type 1, type 2, type 3, type 4. Hyperresponse or hypersensitivity reactions. Obviously, when this happens, we get release of mediators. What do you think is the big one that's going to come out? Histamine is the big mediator, and it produces all the mucus secretions, makes your capillaries leaky, so it allows all the edema to happen of your smooth muscle, to cause smooth muscle swelling. Again, all due to a hyperresponsiveness to an allergen, smoke, whatever the irritants are. Those of you who have asthma, I'm sure you know what your triggers are for your asthma, and you try and avoid those things so you don't have an asthma attack. One diagnosis of asthma does not fit all. So don't just assume that this person presents one way, they have asthma, this one is not presenting that way, they don't have asthma. So epidemiology and risk factors for asthma, it's the most common chronic pulmonary disease. Again, it's usually reversible. More common in boys than girls. Morbidity, mortality has increased in recent decades, despite having great medicines for asthma. Very high-risk populations, African Americans, inner-city dwellers, and premature babies. The very last thing to mature when we are developing as a baby before we're born are the lungs. We don't need them for 9 months because the mom is giving us all the oxygen we need. So the lungs don't worry about developing until the very, very end. So when you're premature, those lung tissue doesn't develop right away. So they have problems with breathing, and then asthma may be a result later on in life. Other risk factors, we have intrinsic, which is non-allergic asthma. This usually happens later on in life. Yes?
Why has morbidity and mortality increased?
Probably because of other confounding factors besides just the medicines. Allergens and pollutants in the air. Yeah, quality of air is bad in certain areas depending on where you live. So intrinsic or non-allergic, later age of onset, decreased apparent allergic sensitization, but very high disease severity. The allergic one is usually in childhood, and usually it goes away. Okay, very mild, 1% may develop full-blown COPD, but regardless if it's an intrinsic or an extrinsic, both share the same features of airway inflammation, hyper-responsiveness to the stimuli or the trigger. So instead of having a mild swelling, they go off the deep end, profound swelling, and they get the wheezing airway obstruction. And obviously the obstruction is there. Triggers, we have your physiologic or pharmacologic mediators. Your histamine is there. Here's your ATP. Allergens, penicillins are here, your animal dander, dust mites. And then other things that can cause or produce airway hypersensitivity or hyperactivity, exercise, your pollutants, respiratory infections, propranolol, aspirin, and NSAIDs. So aspirin, you want to avoid with people with severe asthma. Don't give them aspirin. It can make it worse. And then here's just another sample of many different types of triggers for your patients. So when someone comes in and they have an asthma attack and you're talking to them or in between and they're able to converse, talk with them. What are your triggers? What gives you the asthma? And if we don't know, one of the things you can do for treatment is called a journal or a health diary, a daily journal, where they just will write down, oh, I had an asthma attack. What was I doing right before it happened? You do that for headaches. When you start getting routine headaches, what were you doing when the headache started, especially for like migraines? Oh, I had a chocolate bar, or I had coffee, and that caused a migraine to happen. Aged cheeses and wines and so forth. You're trying to find a pattern. What was going on before it happened? And then obviously they have the allergy tests, the skin tests, to figure out exactly what the triggers are. So, asthma is associated with atopy. Remember, atopy is that IgE antibodies. Gives you that rash on the face. The response can be immediate within 10 to 15 minutes, or it could be a late response. Can be fatal if they have complete obstruction. That's why airway support is always so important. Always watch breathing. And if they have complete obstruction by these mucus plugs, that's called status asthmaticus. If you have mucus plugs, you're not breathing anything. There's no ventilation, therefore there's no oxygen in the body, or reduced oxygen. They still have oxygen, but whatever that mucus plug is occurring, anything downstream of that, whatever alveoli are downstream, are not going to be ventilated. So here's your atopy again. Ig antibodies, response to the allergen. Etiology is unknown. Obviously some genetic component there as well. Common manifestations, allergic rhinitis, just a runny nose. Allergic asthma, the breathing issues. And then your atopic dermatitis, which is your eczema. So these are all these IgE, and the atopy is very common with asthma patients. So, main abnormality, increased reactivity of the airway. It becomes very reactive. No single mechanism serves to explain the entire thing. There are some common events that kind of precede the asthma attack. And one of the things we'll talk about is recognize the central role of airway inflammation in the evolution of the asthma. So, we are exposed to an allergen, something that sets off our hypersensitivity reaction. We get activation of our local inflammatory cells, your mast cells and eosinophils. Mast cells make your histamine. Eosinophils are always your IgE. Goes along with that. And remember, eosinophils goes along is with allergies as well. Okay, these acute acting mediators induce smooth muscle contraction. So all those little bands that wrap around the bronchus start getting very tight now. They start squeezing on that bronchus, reducing the airway. We get local edema, further making soft tissue swelling, making the obstruction worse. Okay, some of those preformed acting mediators recruit additional inflammatory cells, your eosinophils and neutrophils. We have cytokines and chemokines there, which also aid in making local airway inflammation and the hyperresponsiveness. We get T lymphocytes there, B lymphocytes there, and start producing plasma cells, our IgE and our IgAs. More smooth muscle hyperresponsiveness, more epithelial cells get injured. We get growth factors, fibroblasts that drive tissue remodeling, and you get submucosal airway fibrosis. Okay, when you start seeing fibrosis, what does that mean again? It's damaged beyond repair. It's not coming back to normal tissue. And if you have submucosal airway fibrosis, you can have a fixed airway obstruction. And that's when asthma does not become reversible anymore, because now you have a fixed airway obstruction. This is where that 1% of asthma patients will develop COPD. It's these things. Because asthma by itself will not cause it, but these fibroses will cause a fixed obstruction. So you can see here the top picture is looking at a cross-section of the wall. And you can see in normal situations, everything's pretty calm. Now look at bronchial asthma. We have eosinophils showing up. We have a mucus layer that wasn't there before. Remember, these are those goblet cells. Whenever you see a goblet cell, think of mucus. We'll be talking about them a lot when we come to the GI system in a few weeks. The basement membrane has gotten thicker. Look at it there. Look at it there. It got thicker. Swelling is going on, edema. The middle layer, all these macrophages are starting to come in the area. Look at the smooth muscle increasing in size and thickness. Okay, and then obviously your glands start increasing in activity to promote more loss of, or more mediators to get up to the area to cause more of the mucus secretion, more eosinophils in the area, further reducing the lumen for air to move in and out. Okay. So this shows you that cross-sectional area. Here's your normal airway. Now here's your asthmatic airway, and this is at rest. Still has some inflammation at rest. It's not causing any breathing issues, but they still have that underlying swelling going on. Then during the asthma attack, you can see the mucus layer, that the yellow layer got thicker, smooth muscle layer is thicker, the lumen size has gotten a lot smaller, less air can get through. Less air going through causes an obstruction. And that's what asthma is. It's an airway obstruction that's reversible. So again, this kind of just explains everything that's going on. Obviously, the end result is increased airflow resistance. We have narrowing of our airways, increased resistance, mucus hypersecretion, bronchoconstrictor stimuli will also exacerbate the obstruction, mucus layer. It's increasing the distance of diffusion. Less air can get through because now you've decreased the size of the lumen. We got bronchial irritant receptors, and that's your cough. Remember, stimulates the cough. Substance P induces smooth muscle contraction. That's going to make the lumen even smaller because now substance P is also making smooth muscle contraction. This vasoactive intestinal peptide is supposed to promote bronchoconstriction, but we get interruption of it. Low VQ ratios. That's an important one to know with asthma. Low VQ, we're not ventilating, right? When VQ goes down, ventilation is the problem. When VQ goes up, it's perfusion, right? So VQs are going down because volume of air is decreasing, therefore less oxygen. So it causes hypoxemia because you're not diffusing all that. This is also very important. Sorry. Mild hypercapnia is an ominous sign. What is hypercapnia? High CO2 levels. Okay, is an ominous sign during severe asthma attack. Why? Muscle fatigue. Okay, when you have an asthma attack, the metabolic demands go way high and you're using your accessory muscles to breathe. The neck muscles pop out for breathing. You can't keep that up forever. Your your muscles are going to fatigue out and you can't support that breathing anymore. When you can't breathe like that anymore and you can't exhale, what's going to happen to your CO2 levels? Start to build up because you can't get the air moving. So when you're having someone come in with asthma, don't forget the CO2. Check the CO2 levels and see what they're doing. If they start rising, that means breathing is compromised and they're going to crash very soon, meaning you got to intubate them. So watch those CO2s. So what do they get? Chest tightness and dyspnea. Greater muscle effort stimulates those spindle stretch receptors. The hyperinflation from all the big breathing, trying to get all that extra air in. In fact, the air can't leave, so air gets built up in the lungs, causes thoracic distension. When that distension goes up, compliance falls, and the work of breathing increases, and that gives you your chest tightness. Remember, all your muscles that are around the chest, they have to move for breathing. They don't like to work very much, and they tire out fast. As the obstruction worsens, we get an increased VQ mismatch, and that leads to hypoxemia. Less oxygen to feed your tissues. If the demand for the oxygen goes up, but the supply goes down, you start getting pain. Lactic acidosis starts building up. The rising CO2 tension stimulates your respiratory drive to breathe more, and that makes the dyspnea worse. Because remember, CO2 going up makes our breathing more rapid and shallow, to get rid of the CO2. But we can't do that already because we're already having asthma. So now you're making the asthma worse because of that CO2 going up. So with wheezing, smooth muscle contraction, mucus secretions and retention, caliber reduction, turbulent airflow. We're not having a nice smooth lumen. There's mucus in the way now. And when movement of that air goes across those areas of mucus, you get the wheezing sound. That is always common with asthma. This is very important as well. The intensity of the wheezing does not correlate with the severity of the asthma attack. So if you're walking and you're in your emergency medicine rotation, and there's two patients that come in, they both have breathing problems. And you walk by and you're just outside. In room A, the guy is wheezing loud, you can hear it from outside the room. And in room B, they're not wheezing. You can't just assume, well, this guy is wheezing, he's worse. Because remember, we talked about what happens when they can't, the respiratory muscles fatigue out. They're not going to be able to breathe as much anymore. CO2 levels rise. That patient is more severe of crashing than the guy who's just wheezing very loudly. So don't just assume the severity of the wheezing means they're worse off than the other patient with asthma. Cough they get, combo of airway narrowing, mucus hypersecretion, and obviously your neural afferents that are also going to be affected here. They get rapid breathing, rapid heart rate, may be absent in mild disease, but again, in any acute exacerbation of asthma, they're going to have tachycardia and tachypnea. Pulsus paradoxus. The increased lung hyperinflation augments your venous return and will increase right end diastolic volume. Again, causes that septum to move to the left. We talked about that before. When right-sided pressures go up, it can kick out that septum and hit that outflow tract like what hokum does. And when you hit that outflow tract, less blood comes out. So you have that pulsus paradoxus. And hypoxemia, that's due to your low VQ ratios. We're not ventilating anymore, therefore no oxygen delivery to the blood, and you get hypoxemia. Hypercapnia and respiratory acidosis you'll get with asthma. Okay, mild to moderate asthma, ventilation is normal or increased. CO2 is either normal or decreased. This is mild, they're still breathing. They're still able to get air movement, not much, but they can get air movement, so therefore CO2 levels will be okay. But once they get into the severe attacks, muscles fatigue, you get alveolar hypoventilation, hypercapnia results, respiratory acidosis because the CO2 levels are rising. And it's caused by the lungs. So it's a respiratory problem. We get acidosis because of the CO2 buildup. Defects that you'll see on the PFT. So during the active asthma attack, expiratory flow is reduced because of the obstruction. You give them a bronchodilator and you test them again, and the results improve. That's what you want to see with these treatments for asthma. You give them a bronchodilator and their breathing improves. How to look for bronchial hyperresponsiveness. So, when you give a patient with asthma this bronchodilator, you want to see a 12% or greater increase in that FEV1. That means that your cause of your asthma is bronchial hyperresponsiveness. If you can get a 12% increase in FEV1 with giving a bronchodilator, or we give you that provoking factor. So let's say it's dander, and that provokes your asthma attack. We'll give you some dander, and then you have you breathe it in. It will cause an asthma attack. We'll do a PFT. If, when you give you that provoking factor, you get a 20% or greater decrease in FEV1 when you have the asthma attack, that means it's due to bronchial hyperresponsiveness. That's causing that issue. We want to see how well the bronchus tissue responds to these bronchodilators. So with the bronchodilator, we want to see an increase in FEV1, an improvement because we're reducing the obstruction by giving a bronchodilator. So all asthmas do not wheeze, and all that wheezes is not asthma. Remember we learned about cardiac wheezing with heart failure. They don't have real wheezing. It's not due to a hyperresponsiveness. It's cardiac wheezing due to the heart failure causing it. And we'll stop here. What slide are we on? Let me see where we're at here. Still early. Yeah, we'll stop here. Okay, see you guys tomorrow.